Right, I think we'll go ahead and get started. All right, good afternoon and welcome to the Woodrow Wilson International Center for Scholars. My name is Kaylin Ostrowski and I am the Program Associate here at the Center's Global Health Initiative, and I coordinate our Maternal Health Dialogue series. On behalf of the Center, I would like to extend a warm welcome to all of you and thank you for coming to today's discussion on silent suffering, maternal morbidities in developing countries. Enacted in Congress in 1968, the Woodrow Wilson Center is a living memorial to our 28th president, who was the only president to have a PhD and was a strong advocate of bringing the world of ideas with the world of policy. For those of you who are not familiar with the Center's Global Health Initiative, today's meeting is a part of our broader Maternal Health Dialogue series that began in 2009 with support from the Maternal Health Task Force, United Nations Population Fund, and technical assistance from USAID. Throughout our dialogue series, we have specifically focused on neglected maternal health topics, and we are very pleased to be discussing maternal morbidities today, as it is indeed an overlooked issue within the community. Did you know that every woman that dies in childbirth, another 20 women experience acute chronic morbidities, or in other words, near misses, that would otherwise have resulted in death? It is statistics like these that bring us together so that we may identify challenges and discuss strategies for improving maternal health. Thus, in July, we partnered with the African Population and Health Research Center in Nairobi to witness firsthand the needs and maternal health challenges in the field. We spoke with practitioners, midwives, donors, program managers, as well as members of parliament to identify real action steps for moving the maternal health agenda forward. During a live video conference between Nairobi and Washington, these action steps were shared in real time with an audience here at the Wilson Center and provided participants like you with a unique opportunity to directly engage in the Nairobi workshop. We hope that some of you were able to attend that event, and we invite you to participate in another live discussion between Nairobi and DC on October 17th, in which we will discuss how to strengthen health systems through a maternal health framework. Additional details about the October 17th event will be available on our website soon. Before I turn the floor over, a couple of quick housekeeping things. We are webcasting this event live, so what that means for all of you here in the room is during the Q&A, if you could please wait for a colleague of mine to bring you a microphone, we would appreciate it, and please identify your name and affiliation. Now, without further ado, I'm going to turn the floor over to Anne Blank, who is going to chair today's discussion. Anne is the director of the Maternal Health Task Force at Engender Health. The Maternal Health Task Force is funded by the Bill and Melinda Gates Foundation and offers a structure for catalyzing existing maternal health initiatives, deepening the involvement of developing country experts, engaging new organizations from allied fields, and making information accessible to broader audiences. Anne previously spent more than 3 years at the John D. and Carther T. MacArthur Foundation, where she was a program officer in the Population and Reproductive Health Program. Additional details about Anne's extensive background, as well as the impressive bios of our panelists, can be found in the materials you picked up on your way in. Again, a very warm welcome, and thank you for coming. Anne.
Thank you, Kaylin. As Kaylin mentioned, our focus in this series over the last 2 years or so has been on neglected and emerging issues in maternal health, and our topic today certainly fits that bill. Maternal morbidity continues to be a neglected issue. As we all know, a great deal more attention has been focused on maternal mortality than morbidity, and we can talk later about why that's been the case, but surely it has something to do with the way MDG5 has been framed. And we're hoping with this session to raise awareness of the magnitude of the issue and the challenges associated with addressing it. One of the other reasons for the relative neglect, I think, of maternal morbidity is likely because the measurement of maternal morbidity is extremely poor. This slide, which I don't expect you to see all the details, but it shows the best estimates that we were able to find of the prevalence of both overall and specific morbidities. As you can see, many millions of women appear to suffer from various morbidities. And these are probably underestimates, what we have here. But the point of this slide is that the estimates vary widely, almost in some cases to the point of being not very useful. And the measurement is not standardized in any way. So clearly one of the immediate concerns is to improve measurement so we have a better handle on the definitions and the magnitude of the problem. Our three speakers today are going to help with that. They're going to focus on different aspects of maternal morbidity. We'll start with Dr. Karen Hardy, who is president of Hardy Associates. She'll give a general overview of maternal morbidity, and then we'll focus on a few selected morbidities. Also on programmatic approaches to addressing these morbidities, and at the end we'll provide a set of recommendations for improving attention to the issues. Our next speaker will be Karen Beatty, Director of the Fistula Care Project at Engender Health, who will give us an overview of obstetric fistula, its prevalence, its particular features, and also some recommendations for addressing that problem. Finally, we'll have Dr. Marge Kablinski from JSI, who will provide us with some really interesting and detailed information on a program of research on maternal morbidity in Bangladesh. And we should have plenty of time for questions and discussion at the end. So without further ado, Karen, you're up.
Thank you, Anne. It really is a pleasure to be here today to talk to you about this work. And this work is based on a paper that was commissioned by the Maternal Health Task Force with funding from the Gates Foundation, really to look at sort of the definitions and the scope of maternal morbidity, what some of the programmatic issues are related to a range of morbidities, and some recommendations for programming and for moving forward. So I'm delighted, I should say, to have my co-authors with me, Anne right next to me, who will answer all the questions, and Jill Gay, who will answer the questions that Anne can't answer. So it's great to have my co-authors. So let's talk about why focus on maternal morbidity, examples of the range of morbidities, and then some recommendations. We already have heard it. Kaylin said it, and Anne repeated it, 20 to 1. For every woman who dies, we know, and even this number is sort of probably shaky. We see 10 to 1, 20 to 1, 15 to 1. But anyway, we know that for every woman who dies, many, many, many more are affected acutely or affected chronically by these morbidities. As Anne said, in part due to MDG5, but it probably started even before MDG5. So much of the focus has been on mortality with much less attention to morbidity. But we also know that maternal morbidity, and we're going to hear a really excellent discussion by Marge Kablinski, affects women, their families, communities, and societies, affects women's ability to take care of their children, their ability to work, their productivity, and the effects ripple down through communities and society. Right at the Wilson Center last year, Mary Ellen Stanton estimated that the cost of maternal disability, maternal morbidity, costs about $6.8 billion annually. So that's huge. So let's look at the examples of a range of maternal morbidities that we're talking about. And please don't look too carefully about where exactly I put these words, because I'm sure we could quibble about what's exactly acute and what's exactly chronic, but I just wanted to show that for this range of morbidities, and this is not at all an exhaustive list of morbidities, these are the ones that we looked at in our paper. I won't be talking in my presentation about fistula, of course, because Karen Beatty will be covering that next. But uterine scarring, rupture and scarring, anemia, prolapse, infertility, maternal health, all of these issues that sort of go outside the range of the 42 days that we tend to think of in the pregnancy and postpartum period, and sort of get left off with some programming. Let's just look at uterine rupture, the tearing of the uterus that can result in death, but it can also result in long-term morbidities. And the prevalence, of course, of uterine rupture is much higher in... I hope that's not my phone. In developing countries, of course, is much higher than in developed countries where it's just about non-existent with functioning maternal health services. Programming for uterine rupture is this is where an example of programming that is very overlapping with programming to reduce maternal mortality, raising awareness of women of obstetric emergencies and providing access to care, to emergency obstetric care, functioning referral systems that will get women to that care that they need, safe cesarean sections, blood transfusions, and training to eliminate unnecessary practices, unnecessary use of oxytocic drugs, and putting a lot of pressure on the fundus. Anemia potentially affects 42% of pregnant women worldwide, which is huge, with iron deficiency anemia being the most common. And what are the links of anemia to maternal morbidity and mortality? Anemia, of course, affects the ability to withstand the adverse effects of excessive blood loss, of hemorrhage. And of course, we know that hemorrhage is still the most prevalent cause of mortality, but also affects women with increased infection, increased maternal fatigue. And it's also associated with depression, again, fatigue, work productivity, and poor pregnancy outcomes that can affect women in the longer run. Programming for anemia, iron folic acid supplementation. Thailand has been able to reduce their prevalence of anemia in pregnant women from 25 to 17% in just a few years. But so we know it works, but many countries don't even meet current WHO standards for iron folic acid supplementation, and coverage remains low, completely unnecessarily. With integrated programming, looking at the health system, looking at community nutrition, fortification, supplementation approaches, has also, as you see in these African countries, reduced the prevalence of anemia considerably, and much more work needs to be done. And of course, the spread of use of bed nets and reducing malaria is also important for reducing anemia. Genital and uterine prolapse, another morbidity, with the prevalence, this is one of those shaky, from 2 to 20%. We're really not sure what the prevalence is for pregnant women under 45. With uterine prolapse, of course, the uterus slipping from the vagina, caused by trauma or difficulty at childbirth. It's also associated with carrying heavy loads in pregnancy and after pregnancy. The effects of uterine prolapse, difficulty walking. Imagine 42% or 20% of women facing these, difficulty walking, sitting, lifting, squatting, back pain, abdominal pain, painful sexual intercourse, difficulty urinating and defecating, chronic issues facing women. A lot of women don't know that treatment even exists to pay for treatment. They don't have the money to pay for the treatment. In Nepal, a study that was done in 2000 suggested that 57% of those with symptoms of uterine prolapse hadn't had any treatment, and of the 38 women who were advised to have an operation, only 8 did so. So many women around the world now just suffering from uterine prolapse. Programming is the surgery is needed once it occurs, so prevention can help with a checklist on regular gynecological services, assuming those services exist. Reducing women's workload, really sort of counseling about heavy lifting. Getting men more involved, that would be very nice, so that they can take over some of the tasks postpartum. Mental health issues are huge, really. Then they fall into 3 areas. The most common, of course, is depression, postpartum depression. That a lot of it corrects itself and goes away, but still there's still an estimated 20 to 30% of women who suffer from depression in the perinatal period, and some for much longer periods than that. There's a lot of research showing that really deleterious effects of mental health issues, not only for the woman herself, but research about the adverse impacts on infants and children, the ongoing impacts on children, on nutrition status, on education status, on problems with breastfeeding, stunting, kids' own sort of experience then of mental health issues. There are some successful programs for reducing depression, postpartum depression, social support for women and mothers in Taiwan. There's an examples of group therapy in Uganda, use of health mechanisms, and also linking health services and community-based services for women in South Africa, and enhancing the interaction between mothers and their infants in South Africa, and a very interesting study of using community health workers in Pakistan. So showing that there are some sort of low-cost interventions that can do some of the things towards addressing mental health issues. Of course, there's a continuum and some people need much higher level care. There's a real need for mental health to address in the environmental stressors that sort of can help trigger mental health issues. Also, need to look at women who face near-miss deaths, and also who face infant deaths, perinatal deaths, and the mental health issues that they face, and also looking at comorbidities, women who face fistula and the mental health issues they face, or women who face infertility and the mental health issues that they face. So there's a lot of needs in programming. There's needs for training health workers to even understand mental health issues. There's needs for screening in antenatal care, in postpartum care to screen for mental health issues, and also the need to again have community health workers who can work on mental health issues in either programs for children or maternal child health programs. So let me move on to the recommendations that came out of our work. This is a word cloud, and we took a number of, this is primarily the sort of the advocacy material on maternal health. And when I show this, it is not at all to take away from the amazing work. In fact, Karen Beatty and I both have our Women Deliver bags in back here. But we looked at Focus on 5, the booklet that was given out at Women Deliver. We looked at Countdown to 2015, the report of taking stock on maternal, newborn, and child health. We looked at Safe Motherhood Review, a Safe Motherhood Initiative, 1987 to 2005. And we also looked at DFID's framework for results for improving reproductive, maternal, and newborn health in the developing world. And our conclusion here is that our words really do influence our programming. So you can see that if for people reading the advocacy literature, what are you going to work on? Mortality gets so many more mentions than I even started putting in, well, what are some other words I can put in to make the morbidity a little bit bigger? Morbidity, disability, and injury just simply don't show up in the literature. And it's not that all of us working on safe motherhood aren't thinking about morbidity, but we need to articulate it more because it really does shape programs. The DFID, I mean, it again had almost no mention. In fact, mortality only was mentioned in their framework one time, and it was in a citation. It was in the title of a citation. So, as Anne mentioned, we really need much more accurate data for programming. Our estimates are really, really rough. Our estimates not only of incidence and prevalence, but our cost data are insufficient really to guide programming. The child health group had, this is sort of a really interesting quote from their website saying, limited epidemiological evidence suggests that the causal pattern of morbidity is different than the causal pattern of mortality, and information on morbidity could change the way interventions are prioritized in safe motherhood. So stay tuned. I'm so curious to see what evidence they come up to support that statement that's on their website. And again, we need much more information, and actually the Maternal Health Task Force is funding some studies, and Marge will be talking about a really important study from Bangladesh, but there's also ongoing research in Sri Lanka and Kenya on the costs, the burden of disease, and the economic impact of maternal morbidity to help support programming. We also need to know where there's an overlap, where programming that will reduce mortality will also reduce morbidity, and where there's not an overlap, where there needs to be additional programming on morbidity, for example, for maternal mental health or infertility, and really, of course, strengthen the programs that affect both mortality and morbidity, but also put emphasis on programs that just work on the sort of more chronic morbidities. The study in Mexico found that the same effective interventions that could reduce maternal mortality would reduce maternal morbidity associated with some complications, again, but not all complications. Strengthening health systems and improving quality of care, again, to reduce both of them, is going to help both. I mean, if we work on hemorrhage, it has an effect on anemia. If we work on anemia, it has effect on hemorrhage. Skilled attendance of birth, increasing skilled attendance of birth will reduce, hopefully, prolapse, will reduce fistula. There's really interesting work going on right now looking at like near misses, and that using that information both to measure morbidity but also to sort of audit the quality of care that women are receiving in health facilities to sort of trace back what happened. And these near misses are women who would have died had an intervention not been done to save their lives. We need to know much more about how costs of care inhibit use. We also need to know much more about, we're starting to get a lot of information, but still need to know more about community-based interventions. A study, a systematic assessment of 27 studies found that these community-based interventions really could have an impact on reducing maternal morbidities and to improve the care of children, newborn, and related outcomes of children. Of course, we need to reduce the number of unintended pregnancies so that women don't start down the pathway of experiencing morbidities or potentially mortality for unintended pregnancies. And finally, we need to, of course, address the antecedents of poor maternal health, the sort of life cycle things, the nutrition, the sanitation, lack of schooling, agency in families, gender norms, gender-based violence. And particularly, it was interesting in the literature talking about the need for women to remain stoic and not to talk about the complications that they've experienced or their birth experience, and to sort of shatter that sort of gender norm and have women actually talk about these things. The continuum of care has gained increasing currency, and it really is a nice framework to use, but its focus on women in the postpartum period isn't sufficiently long to cover all of the chronic morbidities that we've been talking about and will continue to talk about, and also doesn't really address sort of intergenerational issues of women with mental health issues, mothers with mental health issues, what that does to their daughters, and the sort of life cycle and gender intergenerational issues. So just in closing, I hope we can restore the balance. Maternal mortality, of course, is a critical thing to address, but also to be addressing morbidity at the same time. So thank you.
I have to take my glasses off to read. Good afternoon, and thank you to the Woodrow Wilson Center, to the Maternal Health Task Force, UNFPA, for this invitation to speak, and also to USAID for the support of the work of the Fistula Care Project. Obstetric fistula is a clear example of a health system's failure to support women's needs in childbirth. Access to quality emergency obstetric care services means that this is a condition rarely seen in the United States or in Europe. In those countries, fistula is rare and more often associated with radiation therapies. It's an issue of equity. Women with fistula are often the most impoverished and vulnerable members of society, and isn't there a moral imperative to provide services to these women who have been failed by the system? A vaginal fistula, some of you, I'm imagining many of you may have seen A Walk to Beautiful or read Cutting for Stone, so you probably know something about obstetric fistula. But A vaginal fistula is an abnormal internal opening between the vagina and bladder, or between the vagina and rectum, and it results in either chronic urinary or fecal incontinence, or both. There are three primary causes of fistula. Obstetric fistula due to obstructed labor is by far the most common in the countries where we work, constituting an estimated 85 to 90% of all fistula cases. It's usually caused by several days of obstructed labor without timely medical intervention or cesarean section. And in the course of unrelieved, prolonged obstructed labor, the fetus's head compresses the soft tissues of the bladder, vagina, and rectum against the woman's pelvis, cutting off blood supply to the tissue and causing the tissues to die. Depending on the extent of tissue involvement, the fistula can be small and involve only the middle of the vagina and the base of the bladder, or it may be larger and involve the urethra, bladder neck, and cervix. Iatrogenic fistula can occur, for instance, during the cesarean section when the bladder is accidentally nicked. It can also occur as an accident during surgeries unrelated to childbirth, such as hysterectomy. And in the countries where we work, approximately 10 to 15% of the overall patient caseload is due to iatrogenic causes. Traumatic gynecologic fistula occurs as the result of sexual violence, and usually this is in conflict or post-conflict settings. There are no solid estimates, but traumatic gynecologic fistula can be significant in places where rape, often aggravated by the use of weapons or other objects, is used as a weapon of war. This presentation focuses on obstetric fistula, which is the primary cause of vaginal fistula in developing countries. There's no solid prevalence data. What we do know is that there's a correlation between high maternal mortality ratios and obstetric fistula. The most frequently cited number, as Anne showed earlier, is 2 million cases with an estimated 50,000 to 100,000 new cases each year, but we don't know where this number comes from. The global burden of disease estimate is 654,000 cases, with 262,000 cases in Africa. The DHS would offer us the best opportunity of understanding the scope of this condition, and some countries have begun to include fistula in their surveys, but it is a challenge. The 2008 Nigeria DHS concluded a prevalence of 0.4%. At that level, approximately 150,000 women currently have or have experienced fistula symptoms in Nigeria. This figure is significantly lower than had been thought, but in an environmental scan that we conducted last year, there were a few caveats announced to the NDHS data. Comparisons with DHS data from Malawi and Uganda show that Uganda has approximately 50% of the maternal mortality of Malawi. Uganda's ratio is 435 and Malawi is 984. And approximately 50% of the estimated prevalence of fistula, 2.6% to Malawi's 4.7%. While Nigeria has slightly more than 50% of the maternal mortality of Malawi, Nigeria is 545 and Malawi is 984. The fistula prevalence is only 10% of the estimated fistula prevalence in Malawi, which is 4.7. Again, the stakeholders that we consulted with felt that social stigma may have resulted in underreporting of the condition, that the sample may not be representative of the overall population of women who have fistula. In Nigeria, from an observational study we've recently conducted, 16% of the study participants were younger than 15 years of age at the time that the fistula occurred, and therefore would not have been included in the survey. Homeless individuals were not included either in the survey, and many women with fistula are homeless. It's also possible, however, that fistula prevalence estimates may be overestimated if symptoms of fistula are confused with symptoms of incontinence of a less severe nature. So, as has been discussed before, there remains a lot of work to be done on measurement. I think you can read that. This is what are the consequences of vaginal fistula? This is a daunting list of the physical consequences of obstetric fistula. It's not just a hole and it's not just chronic leakage. The majority of women with fistula develop painful rashes as a result of the constant leakage of urine. They may also develop amenorrhea, vaginal stenosis, infertility, bladder stones, and infection. They may suffer concomitantly from leg weakness and foot drop, and all these conditions require attention. The psychosocial sequelae are similarly devastating. When you first meet a woman with fistula, her eyes are always downcast because of the shame she feels about her physical condition. Many women severely limit their intake of water and food in an effort to limit the chronic leakage so that they become malnourished. They suffer depression and fear, and they isolate themselves from their families and communities in an effort to limit the impact of their condition. For the majority of women with fistula, their babies were stillborn. Secondary infertility is a common result of vaginal fistula, and the resulting childlessness in a context where a woman's status is largely determined by her reproductive functioning can be socially and psychologically devastating. And yet, in a curious way, these women many times are fearless. For those who do find their way to services, they have been told over and again that there is no cure for what ails them. They have searched for an answer in many different places, crossing national borders, before they finally reach a service site that can help them. They may undergo multiple operations in an effort to restore their bodies and their psyches so that they can return to their families and communities whole again, and they persevere. So I'm going to talk a little bit about some research findings. Pioneers like the Hamlins in Ethiopia, Dr. Valdick and Professor Ojengbede in Nigeria, Professor Ouattara in Mali, Professor Gay in Senegal, have toiled long and hard to provide care for women with fistula, but it is only recently that we've begun to learn more about the women with this condition and the services available to them. Research is playing an important part in discovering more about their needs and ways to improve the quality of services. There are 2 studies that were conducted by the Women's Dignity Project and Engender Health in partnership with local organizations to explore women's experiences and their service needs. What we traditionally hear about women with fistula is that for the most part, they are young, adolescent girls who marry and become pregnant too early in their development. When the baby dies and the fistula becomes evident, they are abandoned by their husbands, families, and communities. For sure, there is a segment of the population of women with fistula who fit this description, but it is much more varied than that. In Tanzania, we learned that the median age at the time of fistula was 23, with fewer than half of the women younger than 19 at the time the fistula occurred. And 50% of those women were in their second or higher pregnancy. We learned that delays in seeking care for their delivery were due to access, not so much geographic, but rather lack of money for services and a lack of transportation. While the women with fistula were indeed emotionally and economically vulnerable, they were supported by family members. Most often, the women chose to isolate themselves out of shame and concern for the cost of additional resources for their care and their inability to contribute to family income. In Uganda, using the same methodology, women had a marginally different profile, which you can sort of see here. But of the 76 women who were interviewed, only 3 in this study recalled being told anything related to delivery during antenatal care, and no counseling was reported on risk factors or warning signs and symptoms. In pretty much all the countries where we work, we come across cases, and not rare instances, of women who've lived with fistula for 10, 15, 30 years, and some have continued to have children with the fistula. To further illustrate this point from a more quantitative standpoint, I'll share with you now some of the descriptive results of a prospective facility-based study we've recently concluded in 10 sites in 5 countries. The overall objective of the study was to look at the determinants of postoperative outcomes in fistula repair surgery, and we're still reviewing and refining the analysis of that data. But the descriptive data is interesting. The data on the following slides is from those women who had a fistula surgery, the 1,354 women in the 3rd box. So these are some selected baseline characteristics of these women. The ends are different for two reasons. Sometimes we're missing data. For example, nothing was recorded on some forms, as is the case for the age at first marriage. And sometimes we're looking intentionally at a subset of data. For example, the number of women who have had a previous repair surgery. So median age at first marriage was 15, while median age at occurrence of fistula was 20 years. Median age at repair was 25 years, which would suggest that on average, women had their fistula for 5 years. However, the duration of fistula in months is only 12, so we need to explore this further. This is one of the challenges experienced with self-reported recall data I'm sure you're all familiar with. We asked women their age and the month and year that their fistula occurred, and using this information calculated the age of fistula occurrence and the duration. If some women don't know their age, it may also be difficult for them to recall the month and year that their fistula occurred. But it's also interesting to note that the median parity at repair was 2, and almost 1/4 of these women had had at least one previous repair. This is just another representation of the data of age at fistula occurrence and the time for repair. Along the bottom axis are the study sites. Actually, there are the countries and the number of the study sites. We agreed that we wouldn't share the names of the individual sites. They're in order of ascending age at occurrence of the fistula, the light blue. And you can see that at some sites, the age at fistula occurrence and age at repair are fairly close, while others, the women seem to have their fistulas longer before undergoing repair. Most women in the study were married. Again, remember we heard earlier that these are young women who've been abandoned, although just over 1/4 reported that they were divorced or separated. A little more than half of the women had less than a primary school education, with about 1/4 reporting religious studies, mostly Quranic. And the vast majority of study participants said they were rural residents. This final slide notes that, by the way, there were multiple options to these two questions, shows that most women actually were living with family members, about half with their husbands and more than 1/3 with one or both parents. Few women lived alone. About 70% of the women lived in a residence that had a radio, and over a third in a residence where someone had a mobile phone. Other utilities and commodities were rarer. So what are the causes and phases of obstetric fistula? In most cases, they are medical, resulting from prolonged and obstructed labor. But as with other causes of morbidity, there are other determinants that contribute to the obstetric fistula. Essentially, the same delays that result in maternal deaths are the ones that result in obstetric fistula. And you can see those on this slide. So what do we need to do? From the previous slide, you'll see that obstetric fistula is amenable to the solutions that we have already identified to address maternal mortality. Focusing on prevention is the key to addressing fistula. The Fistula Care Project has targeted a package of 4 key interventions within the panoply of packages of maternal health interventions that we believe will have most success in addressing obstetric fistula. Access to family planning to delay first births, facilitate spacing, and for those who desire it, to limit the number of children they will have. Women are generally advised to abstain from sexual activity for 3 months after the repair and to have a C-section for any subsequent pregnancies to prevent a subsequent fistula. Many, not all physicians, would prefer a longer period of healing before a pregnancy is attempted, and so the use of a method can help to achieve that. For women for whom fertility is still an option, access to information and support for the standard days method could also be useful for women to help them achieve a successful pregnancy. Correct and consistent use of the partograph. The partograph remains the most underutilized tool available to pretty much everyone in midwifery care, and its potential for identifying complications and ensuring that action can be taken has yet to really be realized. Catheterization immediately after prolonged or obstructed labor is a standard of care that is also often not used. This could prevent fistula from forming, and in addition, there is some evidence to suggest that the small, fresh fistula catheterization might lead to healing without the need for further surgical intervention. Finally, increasing access to emergency obstetric care and improving the quality of cesarean section performance will help to prevent both obstetric and iatrogenic fistula. The majority of fistula can be closed surgically. It's misleading, however, to suggest that fistula surgery is simple. The degree of injury will determine the complexity of the surgery, and I previously showed you a list of some of the potential injuries that can occur. Fistula are classified in varying systems, from simple to complex, and I'm told reliably that the majority of fistula are complex. Closing the hole is also often not the end of treatment. Data suggests that between 20 to 30% of women with a closed fistula may have some form of residual incontinence after surgery that will require further attention. And for some of those women, this may never resolve. Small women may have what we're now calling persistent fistula-related pelvic floor disorders. We have to find a shorter way of saying that, for which fistula repair is not the answer. And standards and guidelines are needed for the treatment for those women, and we've begun the process of working with professional associations and others to discuss this. The good news is that increasingly the field has moved in partnership to standardize care with new tools and materials to support that care. These are some of the materials that are currently being finalized or have been finalized. And here I have to acknowledge the work of the International Society of Obstetric Fistula Surgeons, the International Obstetric Fistula Working Group, which is part of UNFPA's campaign to end fistula, the work of FIGO and the Pan-African Urological Society, as well as the collaboration of those providing fistula surgery across Africa and Asia. This is the final slide. There are very strong, capable fistula surgeons in Africa and Asia. No one is going to become wealthy through fistula surgery, so it requires a special soul to do this work. What is needed are the resources to support continuing training for future generations of surgeons and surgical teams, and for the services they provide in health systems and budgets that are stretched to their limit. Many individuals believe that fistula services should be available at every district hospital, but this is neither feasible nor desirable. There are insufficient surgeons with many more things to pay attention to, and each surgeon needs to be able to work on a sufficient caseload in order to maintain and hone his or her skills. Training surgical teams is necessary but not sufficient for strengthening the capacity to provide treatment services. The service site needs to be equipped, managed, and supported to provide this service. Without the necessary infrastructure and management capability, the surgeon's skills may not be realized to its full potential. To address this desire of everyone to be involved in fistula, but at the same time maintain the quality of services, our project has proposed and is working on a levels of care framework to address fistula. In places like Uganda and Guinea, the national health systems are working to determine at what level of the health system they can integrate these levels of care. So, for instance, in Uganda, case identification, diagnosis, and referral might be at Health Center 3 and 4 levels, while repair would be at a regional or specialist hospital, with training sites designated initially at those sites that have been providing fistula services and training on a long-term basis. In Rwanda, the ministry's goal is to have 5 provincial hospitals providing fistula repair and 2 or 3 training sites, with prevention work integrated into all aspects of its Safe Motherhood program. Reintegration is something that needs to be addressed for all women, but not all women require reintegration. Remember the data that I provided you earlier. For some women, resolving the fistula is what is needed to return to their lives. For others, it is more complex. But that's a subject for another day. Thank you.
bring up your show first. Oops.
Hi, I'm Marge Kablinski, and I'm absolutely delighted to be here to thank you, Anne and Woodrow Wilson, for inviting me to speak about the maternal morbidity study that we've carried out in Bangladesh between 2007 and 2008. And you see the list of characters here involved, and I would just like to point out a few. Ilahi Chowdhury essentially was the field manager and director of the project in the field, and we also had the technical support from the London School with Karine Ronsmans and Tim Powell-Jackson. Actually, you've heard quite a bit of this conceptual framework in the talks which we've heard so far, but I'd just like to go through this because this is how we grounded our own study. You start with the acute maternal morbidities. These are primarily the morbidities that happen during labor and delivery, including the obstructed labors, including the postpartum hemorrhages and so forth. It's the 15% that's been made very famous to date, but as we've heard, the actual numbers of those complications are still hard to actually measure. From those acute complications, we anticipate there are short and long-term consequences, which you have heard about. These are the women's disabilities, as we call them, including the incontinence, the fistulas, the prolapse, dyspareunia, and so forth. There's also death, obviously, and there's also psychological consequences. For the child, that index child of the mother, you also have problems of growth and development as well as survival, and this comes not only from the acute complications but from the management of labor and delivery itself. The effects of both the child, on the child as well as from the mother, impact on the family and the household, and we've heard a little bit about that already, especially in the last talk. At the social level, less social support, the woman is stigmatized, or the family is stigmatized. You have a family disruption, you have divorce and so forth, violence as well, and at the economic level, further impoverishment of the family. So with that as the beginning of the framework for the project, we then went into the project itself with the specific objectives as follows. We wanted to determine the level of severe and less severe maternal complications of those women who gave birth in facilities. And I'm going to emphasize here that we wanted to look only at the women in facilities because we felt that the diagnosis would be more appropriate and more valid. We wanted then to compare those women with women who had a normal vaginal birth for their consequences. This is the level of physical sequelae at the end of 6 to 9 weeks post-delivery. We wanted to look at the newborn outcomes, death and the developmental delays, and the consequences of the consequences, the psychological, social, and economic impact on the family, as well as the continued death of the child or the children and the mother. We carried this out in Bangladesh, and I'm sure many of you have heard of Bangladesh. It's a very rural area of Bangladesh, located about 50 kilometers southeast of Dhaka. See here, it's a farming, fishing area in which the ICDDRB has had a field site since approximately 1966, in which we've had first the cholera vaccine trials, followed by family planning programs, and followed more recently, meaning starting in '87, this has a history here, in the maternal field. This has had surveillance since the 60s. So you have an ability to track families, you have an ability to track the mothers themselves. But even so, even though the ICDDRB has been involved in this particular site for decades, we still find that the literacy is approximately the same in Matlab as it is within the whole country. You can see here, CPR and TFR are also about the same, but the rest of the indicators that I've put here are quite different, and that shows you that the maternal health program is actually having an impact in terms of both use of services, use of skilled birth attendants. Here you can see 77% versus the Bangladesh level at 2006 of 18%. The C-section rate is up higher. It was about 12% in 2006 versus the 7.5%. And the impact on maternal mortality and on the neonatal mortality is obvious. 240 versus 322, 20 versus 37. So there are differences in the community between Matlab and Bangladesh. So what you're going to hear is most likely a representation of Matlab, but it's also a big question as to whether the morbidities that we see at the level we see them in Matlab are also the same in the rest of the country. First step is to look at the acute maternal morbidities and death. And as I said, we drew from the community where you have community surveillance, so we actually had workers going out and able to find those women who had delivered in the past couple of weeks. That list of women and where they delivered was then given to a couple of physicians who went to the approximately 30 hospitals in the area to track their records. And so it was through that biweekly record review at the facilities by the physician that we were actually able to find the women who had suffered a severe or less severe delivery complication. We also selected women who had had a perinatal death. We took a sample of women who had a normal birth. That was the control group. And we also looked at a sample of women who had had abortion. But in this talk, what I'm really going to focus on are the women who had the severe and the less severe complications. I'll also speak later on a little bit about the women who had a perinatal death as well. And obviously the control groups are always the women who had a normal vaginal delivery. Slowly here. Over the course of the 2 years, we had nearly 5,000 births. We were able to track of the 2,100 records of the women who were in facilities. We were able to track all but 175. So we have about 1,927 records that we could find. We missed the 8.3% because the records couldn't be found or they weren't legible or for whatever reason. And we missed the 4% who went to hospitals outside of the Matlab-Chandpur area. Essentially, they went to approximately 95 hospitals outside of our own area, and we just couldn't follow them up. Categorization of the morbidities, and this is actually a very important step for anybody who wants to take on this kind of research to try to understand which complications you're going to consider as severe, less severe, and so forth. And there is now some guidance in the literature, both from Corinne Ronsman's work recently, 2009, 2010, I think, as well as Lali Say's work and the WHO in terms of near miss. We, at this time in the life of maternal morbidity, this was 2007, so we have used a definition here which includes C-section due to the absolute maternal indications, many of which are now in the near-miss category, including placenta previa, abrupt placenta, major cephalopelvic disproportion, malrepresentation, etc. Hemorrhage, bleeding with shock or had two units or more of blood, eclampsia and severe preeclampsia, septic shock and septicemia and severe anemia. So what we're trying to do here is find the most severe cases in order to follow them up. The second category was less severe. We also looked at women with C-section with no maternal indications and vaginal deliveries with no maternal complications. Okay. So of the 1,927 records which we could pursue, and this makes up approximately, as I said, 44% of the total population giving birth at that time, 141, or approximately, I think that's 7%, had a severe complication. And most of those severes, as you see, are dystocia. which came as a surprise to us. We anticipated seeing many more women with hemorrhage coming in, but hemorrhage is the second one and much lower in terms of women coming into the hospitals. Severe hemorrhage was 12.8%, followed by severe preeclampsia and eclampsia at 11.3%. If you look at the less severes, dystocia again is the primary problem at nearly 70% of the total whom we classified as less severe. Followed by dystocia. Dystocia is obstructed labor, simply. Okay, prolonged obstructed labors. Other hypertensive disorders, okay, in your less severe cases. So a total of 7% of the women who were in the hospital had a severe complication, double that less severe complication. When we looked at those 401 women who had a C-section, we find that only about 28% of them had extremely severe complication, the absolute maternal indications plus those others which were considered severe. 18% of the C-sections were for the less severe complications, and the rest, 56%, were for other issues, either unknown, fetal indications, failure to progress. And amongst the deaths, what we found, which is not surprising, was that 6 out of the 12 deaths were still from hemorrhage. So even though your dystocia, obstructed labor, is the big problem for the women coming in to the hospitals, it's hemorrhage still that kills. So in summary for this first step in the study, looking at the acute morbidities and mortality, what we find is that only 7% of the women who delivered in facilities had a severe maternal complication. Most of the complications were due to severe dystocia. Hemorrhage and sepsis were minor components in the hospital. C-sections, about 28% were provided for severe complications, although if you looked at amongst those women who had a severe complication, 79%, 80% had a C-section. 18% were for less severe complications. Again, if you looked amongst all of those who had a less severe complication, about a quarter of them had a C-section. And again, as I said, about 50% of the deaths over those 2 years were due to hemorrhage. Now we go into step 2, which is the consequences for the woman, the physical disabilities. And again, we're bringing women back to a facility for an exam at 6 to 9 weeks post-delivery. And the sample that was selected, and this is not a population-based sample, this was based on specific criteria of the women who came into the study. So we wanted to look at those women who'd had a complication, severe and less severe, and we took all of those who were severe and half of those who were less severe. We took all the women who'd had a perinatal death, all of the women who'd had a C-section without a maternal indication, and a sample of the women who'd had a normal birth, vaginal delivery. And obviously, when you invite women to come back, not all of them do come back, so we did have some dropouts in this case. So when you compare women at 6 to 9 weeks postpartum who'd had a complication and look at what kinds of physical problems they had, you find significant differences between those who'd had the complication and those who had a normal birth. Amongst those with the complications, they had more significant levels of hypertension, anemia, and hemorrhoids. But the women who had the normal deliveries had far more perineal tears and genital prolapse. So normal deliveries also result in some major problems for women, and at quite high levels. The other thing, just note, genital infections and urinary tract infections are high for all. High meaning nearly 20%. Amongst those who'd had a perinatal death, what we find is that the significant difference with those women who'd had a vaginal delivery, normal, genital infections was a major problem. Amongst those who'd had a C-section was protection by the C-section against prolapse and the perineal tears and UTIs. So these are all normals. The blue bars are normal vaginal deliveries, and they obviously have a much higher level of prolapse, perineal tears, and UTIs. Neonatal deaths, 5 times the level of neonatal deaths among the women who'd had a complication. And that continued to play out. The child, even up to 2 years post-delivery, children of women who'd had a complication were significantly, had significantly higher levels of death. So in summary, with regard to the physical disabilities, we have women with complications are more likely to suffer with hypertension, moderate anemia, and hemorrhoids, and neonatal deaths. And the women with complications in childbirth are less likely to suffer from genital prolapse and perineal tears. And this is most likely related to the high levels of C-section for those who had complications. So now we go into step 3, which is the consequences of the consequences. And here I'm not going to show a lot of slides. I'm just going to talk to the impoverishment factor and I think the depression piece. And here what you see is that the cost for those families with women who'd had a severe complication or less severe complication was extremely high. It was nearly $300, and most of that was the cost of the C-section or for the time spent in the hospital for treatment of those complications. And you'll note that that later on, the costs of care were very, very low, and a lot of this is because women with postpartum complications or disabilities essentially don't go for care to a large extent. And again, what you find, what you can expect, I suppose, is that amongst the poor, they were the hardest hit with such complications. This is the quintiles for the severe, less severe, and the normal. And what you find is that for the poorest, 35% of their annual income was used to pay for the complication treatment. Depression. And what I can say here is that the depression was not in relationship to the complications. We did not find a significant increase in depression because of the complications. It was primarily because of the perinatal deaths. And so you find that women who had had a perinatal death had 4 times the level of depression at 6 weeks. At 6 months later, that had resolved itself. But she still felt negative social consequences. And that negative social consequences is defined as negative life changes, worse relationship with marital family and with the husband. Don't ask too many questions about that. It's hard. So I have about 5 or 6 slides in summing up. And here's the famous tip of the iceberg business. We had 12 deaths out of 4,800 some odd births, so you have an MMR here of about 225, I believe. We had 1 maternal death for every 12 severe complications, and 26 less severe complications. This adds up to 1 maternal death is equivalent to about 38 complicated cases. I think this doubles the ratio of what we'd heard before, the 1 to 20. And it results in, if you take these to the international level, which you probably shouldn't do, it would result in about 20 million women worldwide. Consequences. also the consequences of the acute morbidities. We often hear that they are also at the level of about 20 million women per year, and that's very, very low compared to what we find. We found that approximately 40% of all women had some kind of problem postpartum. The hemorrhoids, there were hernias, there was incontinence, and so forth. 40% of the women postpartum had a problem. And typically these were not treated. We had 4 hypotheses which underlay this study, and the first one is that women with severe obstetric complications suffer more long-term consequences, the physical, social, mental, or death, compared to those with a normal delivery. And what we find is certainly, yes, the severe complications do lead to death, as expected. Physical consequences are common, as I've just talked about. There's over 40%, but they're relatively mild. First-degree prolapse, hemorrhoids, and hypertension. The social aspect is acute, however, for the few women, and this is Bangladesh, not the sub-Saharan African countries, which Karen has just been speaking about. But in Bangladesh, where there's very few who suffer the fistula, there's more stress incontinence and second and third degree prolapse. They experience, as Karen spoke about, absolutely devastating social consequences of stigma, verbal abuse, violence, divorce, societal ideation. Mental. There was no significant or long-lasting depression, no postpartum depression as related to the complications. Okay. So now hypothesis 2 was women with severe, less severe complications, and those who die have poor pregnancy outcomes. So we're looking at the newborn and the child. And here we find perinatal deaths are twice as likely amongst the women with the severe, less severe complications. Neonatal deaths, as I said before, 5 times the level. Infant mortality is about 8 times higher in the case of a maternal death. If a mother dies, 8 of the 10 children under the age of 10 are likely to die compared to 1 in 10 for the normal. And this has been published, I think, along with the Women Deliver conference. There was a Lancet series that came out, and Corinne's article comes directly from this study in which we talk to this high level of children dying when they have a mother who's died. The consequences of perinatal death on the mother includes postpartum depression. So essentially the mother, if she has a complication, you don't find the depression, but if she has a perinatal mortality, you do find the postpartum depression. Emotional violence and controlling behavior from both the family as well as the community. Next hypothesis is a child of a mother suffering the consequences of severe obstetric complications is at higher risk of death, poorer growth, and development. Well, we've just talked about the death aspect, and essentially what we find is that there are no significant developmental delays in relationship to these morbidities. The last hypothesis was that they would be at higher risk of impoverishment, and that's absolutely clear. It's very high in relation to the household income, and especially amongst the poorest. But essentially the family at 6 months appears to recuperate. The consumption of the family is not changed at 6 months. So the policy recommendations, and this follows on what previous people have spoken about, promote postpartum follow-up within that first 6 weeks and broaden the aspect beyond newborn care and family planning to also have a look at hypertension, hemorrhoids, and anemia, especially for those with a complication, and for prolapse and perineal tears, especially for those who delivered at home. And that follow-up needs to be continued for at least a year because there are now reports from India as well as I think it's Burkina Faso where you find excess maternal death as well as infant death in that first year postpartum. I think one of the signal factors that we found was that the perinatal death is a huge impact on the woman, And there needs to be a targeting for those households with women who have had a perinatal death, for family counseling. It's not just the woman, it's a family that needs the counseling for her postpartum depression, but also to alleviate the domestic violence that can ensue, as well as the social impact. Financial protection for the poorest is an obvious last recommendation, and one that I'm very pleased Bangladesh has actually put into place now. Thank you very much.
Well, thank you to all of our speakers. It was really quite a litany of distressing information, I have to say. I mean, it really is distressing. And because of that, I would like to invite Karen Beatty to start to talk a little bit about some of the work that the Fistula Care Project has been doing to resolve some of these problems. I know that you've done 20,000 repairs, is it? Yeah. And do you want to talk a little bit about some of the other work that you're doing to address fistula? Something positive would be good.
So yeah, I mean, I think it's the work of the Fistula Care Project, but also of other projects that are supported by USAID. There are bilateral projects that are also working on fistula. It's also the work of the International Obstetric Fistula Working Group and others. But through the Fistula Care Project, we actually have been building the capacity to provide fistula care services. We're currently working, as I think I said, well, maybe I didn't say, but we're currently working in 10 countries. It has kind of varied between 10 and 13, depending on certain things. And we're really working in a very intensive way in partnership with the National Ministries of Health, with national technical working groups to address some of the policy and advocacy issues that working towards integrating fistula into the broader safe motherhood or other maternal health strategies that they have in those countries. So that's a very important part of our work. And then more specifically, we're also supporting the treatment services for these women. We are helping to develop the capacity of the service sites. As I said, it's not really training surgeons is good, but it really is important that you establish a service at a service delivery site so that if the surgeon moves on, there is some ongoing services there. And I think also we are trying to link with communities to create awareness of fistula and its causes, to integrate the messages about fistula into other safe motherhood prevention strategies, a variety of interventions like that. And as I said, really on the prevention side, it really is a question of simply integrating information about fistula and some of these other morbidities into safe motherhood strategies so that people become aware of what the causes are and what the potential sources for treatment are, and that we can do something to try to reduce the stigma that many of these women experience. Does that help?
Yes, thank you. We have some time for questions, comments, more positive stories. Yes, Jill.
It's coming. It's coming.
Please identify yourself and your affiliation.
Thanks. Jill Gay, co-author with Karen Hardy of The First. And my question is for Marge about what Bangladesh is, and I'm hoping this is a positive, what Bangladesh is doing to decrease the financial hardships, and how I was shocked to hear that C-sections are, are there charges for having a C-section for poor families? Has that been waived? So that's my question.
Well, I hope it's positive. What I really don't know, I left Bangladesh in 2008. I understand that there is a voucher program now in place, and the voucher program I believe was aimed initially at poor women. I had heard that in some districts they were trying for all women to protect them from the costs of maternal care and impoverishment. So I trust that that has continued, and I understand it has, but I don't know how successful it's been.
Yes.
Hi, my name is Nicole Warren. I'm on faculty at Johns Hopkins University in the School of Nursing. I had a question for Ms. Beatty. You mentioned that obstetric fistula has 3 main causes, and you started to give us a breakdown of which account for most of it. It's not like obstructive labor. Is it in a setting like, and you may not know of this data, but if it's out there, you might know it, in a place like, for example, DRC, where sexual violence prevalence rates are so through the roof as compared to other countries, do you have any idea how fistula might break down in a place like that?
So again, the DRC in some ways isn't that different than other places, even though there is this experience of sexual violence. The majority of it is still obstructed labor. Some of that could be a contribution towards the occurrence of obstructed labor is the limited access to facilities, so women can't actually get to the facility. So it is also a consequence of the violence. Nonetheless, we only have service delivery related data, and in 1 or 2 sites that we support, it probably accounts for 1% of the fistula cases, and that will obviously increase when the violence increases and decrease when it's a little calmer. So that's really the data that we have right now. There is one paper, I'm sorry, I forget the name of the author, but there is one paper that looks specifically at the data from the Panzi Hospital. But again, it will change according to whether or not things are calm or the violence has increased.
Yes, Mary Ellen.
Mary Ellen Stanton, USAID. I'd like to thank everybody for this. It's so important, and it's so good to hear some of the research that's coming out recently about this. As I was thinking about this problem of getting attention to it, there are the measurement issues and the definitional issues, which seem to have caused, maybe those were the major reasons. But then I'm looking to a positive in looking at the galvanization of interest around obstetric fistula. And I'm trying to think how that happened. And from my perspective, I think that Catherine Hamlin coming to the United States and lobbying people in the U.S. government, the work of UNFPA, the work that it was done in terms of movies, of the stories that's come out of fistula care and so forth, that we, not we, but others were able to convey the tragedy of the problem to people who were had enough power to make a difference to start getting going. Recognizing that we haven't begun to tackle that totally. There's a lot of work going on. And then I contrast it, say, to anemia. Which has to be the maternal morbidity that has, for the number of women affected, hasn't tugged at anybody's heartstrings whatsoever. And that as we look to get a better handle on the numbers, which we always should have, that I think we have to tackle each of these morbidities separately. Mm-hmm. That we could link on prolapse to what's going on with fistula if we're careful and do it right and not lose attention to fistula. But there are some others, for example, anemia, that needs a different strategy. And I don't think unless people start caring about the women who are suffering from the problem and the consequences of the consequences, which are really subtle. Well, they're not subtle to the women, but to the rest of the world. And I just wonder if we looked at each of these not just as a group, but one by one, what we could do to garner attention in a way that would be more effective. And I don't know if anybody has any comments about that.
I'd like to start with that. I think you're right. Each of the conditions needs sort of separate attention. But I go back to the graph, the maternal mortality graph. What is it that what are women dying of? And I'm thinking if we talked about hemorrhage separately and we talked about all of those different components separately, to me it's really compelling to see them all together. So I think as we were working on this paper, there's a lot of literature about fistula, about each of the conditions separately, which is really good and compelling and helps with programming. But to me, it was putting it all together to show what the consequences of the consequences of the consequences are of, women facing so many of these conditions and comorbidities that I think we need to tell, and at the advocacy level, both stories, both the individual stories of each of the conditions, but how they affect women's lives combined, and not only women, but the effect on their children and on the families and societies. So I think we need to be telling sort of both stories.
Yeah, I totally agree with that. I think that looking at this as fistula affects a relatively small number of people if you look at other diseases and conditions that we're addressing. And so in a way it is more amenable to looking at things in a more holistic way. I do think, though, Mary Ellen, as you raised, the importance of champions maybe for each of these specific morbidities is something that is critical. I know that in my particular instance, my mentor in this was Maggie Bangser and of the Women's Dignity Project, and she did a lot of work to bring both UNFPA and Engender Health into the fold when she was at the Ford Foundation and basically create the awareness of these little pockets of service provision that were going on in the different places. And that then galvanized, and enabled those people who are very strong advocates of the work that they do to actually begin to come and speak out, both in their own countries but also elsewhere. And so I think that having champions and having good stories on each of these issues, in addition to thinking about them holistically, is perhaps a good strategy.
Of course, I'd like to use this as a means of segueing into postpartum care, because to me, what it signals is that there's a lot more morbidity than we have been paying attention to. It's happening in the postpartum period. Women are not coming in now for postpartum care. Postpartum care has a lesser role in life than antenatal care. And I think we need to be focusing on extending postpartum care very strongly and with specific foci. I mean, if you find a woman who's had a perinatal death, that woman really needs attention. I think also that you will pick up women with prolapse who state that their life is not going well. And that type of thing really needs to be listened to. So I'm hopeful that we're not only talking about advocating for learning about more numbers and so forth, but advocating for a programmatic focus on postpartum care that goes way beyond the 42 days.
Yeah, and I think that just to add to that, that the postpartum care needs to focus not just on the child, which I think the baby, which I think it tends to do now, but really make it clear that postpartum care is about the mom and the baby at the same time. So, yes, Debbie.
Sorry. Debbie Brewster, USAID. And again, as Mary Ellen said, great presentations, lots more we all have to learn, I think. But this was wonderful to be able to hear these things. I just was in Nepal recently, and one of the things that shocked me was we were doing field visits, and we came to a hospital, and there were women lying all over the place. And we said, what's happening here? And they said, it's prolapse day. all of these, and I went, what? The whole hospital was filled with women who had such significant, I'm sure it was all hysterectomies. I was doing other things, but I was just shocked to see them all sitting around. And, you know, some of it is, I had no clue that there was that kind of problem, that they could actually have campaigns to bring women in on an issue like this. And so my thought is a little more around, where's the data collection? Where's the information sharing, even within countries? Clearly, Nepal has figured out, or at least that area, that they needed this. But just to be able to share that kind of information and to have data. So I guess that's the question or request. I think we need more data collection on these different issues and pulling it together to share these kinds of stories, you know, and particularly country-wise.
Yes, Sarah.
I'm coming. Coming.
Thank you. Sarah Craven with UNFPA, and I want to echo my USAID colleagues in saying this was long overdue and fantastic to see these issues raised, so thank you for that. And maybe like pulling up on what you just said, in Nepal there are NGOs who are advocating on uterine prolapse, and there's a strong NGO community who's raising that issue. And I guess maybe I'd like you all to focus a little bit on turning this need for data collection to the policy level, and what could we be doing more to be raising these issues, because there are no resources for data collection. How could we be, in some of the work UNFPA has done on fistula, I've had people critiquing us almost for raising this issue compared to other needs or other issues in global health. So how can we take some of this and turn it into the policy agenda? What do you think are strategies that we could be doing? Such as working with NGOs at the community level.
It really is a challenge for things like uterine prolapse and for obstetric fistula. One of the strategies that we're beginning to explore in Nigeria is this issue of community screening. A little bit, well, it's not quite what you've done, but I mean, really trying to get some kind of reference of prevalence incidence data. It's really not prevalence incidence data, but getting an estimate of what the numbers are in a community screening protocol. And but the challenge with that is that then if you screen, you have to actually have the ability to treat, right? And so, you know, you've got to really kind of figure out how you're going to do this and where you're going to do it. So it's a very complex thing for us. And that, I think, raising those kinds of discussions with the administrations that are organizing services is really the way that we're trying to struggle with this issue. I'm not sure that I have a more succinct suggestion than that, and if you have an idea, I'd like to hear it from you.
And I can't believe I'm saying this because I'm a numbers person, but I've been told by many of my advocacy colleagues, you say too many numbers, tell stories, tell stories. You know, the individual stories that we've been talking about can be so powerful for policy advocacy, you know, in the absence of good sort of statistics. So I'm encouraged to continue with those. The things we were just talking about with fistula, the films, the stories, you know, bringing people together. But to me also the evidence of the effects of these morbidities. I don't think we've talked enough about the effects of these morbidities on not only on women, because we know a lot of times policymakers don't really care about women themselves, but you know, on the families, on the kids, on the societies that might resonate with some policymakers also.
I guess I would also advocate for piggybacking. I think the newborn agenda is already out there. It's at the right time. Is there a possibility to piggyback on some of the work that the newborn group is doing, which could also assist with women's care? So, you know, there's lots of effort now for postpartum or postnatal visit for the newborn at 3 days. We should do that for the woman as well. You build in some indicators for checking women. As you go out in time, we should also have the same overlapping visits for the woman as well as for the newborn, and begin to talk about, bringing some identification of prolapse, of the hemorrhoids, of the anemia, to those same visits. I must say this was probably one of the hardest studies to do. This is not an easy kind of work to be done, and I'd like to hear more about the task force studies that are ongoing. But if it hadn't been for the very long duration of interaction between the ICDDRB staff with the women, I doubt very much that we would have been able to bring women back in for vaginal examinations. That just was not something that was easily performed. Or to be able to talk about violence in the relationship of the family. You need a very trusting relationship for that. So those are some of the very much harder pieces to do in a setting, types of morbidities to get at or consequences to get at. So I'm not sure that I would advocate for a lot more studies on this. I think I would go much more in the direction of programmatic as well as advocacy through the stories.
I had a comment. Thank you, Mary Carnell from JSI. Actually, it was very similar to what Marge was saying. I was thinking also of Hillary Clinton and the 1,000 days, the 1,000-day window. I'm not sure exactly where that effort's going, but the pregnancy period and the 2 years, and we're particularly concerned with nutrition in that model. But I think the piggybacking, the missed opportunities are quite important, and immunization is probably one of the programs that has the highest coverage, where it's usually the mother bringing in the child, from birth really up till 1 year, and sometimes later if there's other delays. And it's not going to be just a lone immunization worker that can do all these other things. But if we bring in often the family planning workers I was just in Bangladesh last week, they're off working alone, and the immunization workers are working alone. And we have studies from 20 years ago in Bangladesh. If the family planning worker would just come to the immunization session at satellite or outreach, they can get a lot done. And I think integrated kind of checklists can help, but I would what Karen Beatty was saying about we can't put it out there. It's hard to do everything. And I think programmatically, if we can start with something, if we can say there's some low-hanging fruit there, I'd leave it to you to decide what that fruit is, but to build on programs. And, you can maybe get one service there before you can get 5 services. And to build on something and start to go and add those to your kind of screening checklists, I think there's some work there. But, when you look at the mental health, and you look at mental health for everything, in most of these countries it's so low level and so little reach that, that's cutting off a very hard one. But, we're always for prevention first and treatment later. And so much, when I look at the numbers, though, we ask for more numbers. DHS has been tracking anemia numbers for quite some time, and I don't see much traction. The numbers are there, and it's awful for both the child and the under 5 children and the mothers. And, nobody's doing very much about it. So, thank you.
Maybe I could ask a question, and for those of you who've been involved in the costing, the asks for maternal health, are morbidities really well integrated into the costing models for maternal health?
No, they're not in the global. They're not in the global burden of disease.
So maybe asking for more money, but for the morbidities, so that there is more money for programming. And Sarah, UNFPA is involved with WHO in an initiative to integrate maternal health mental health into sort of SRH. And is that going well? Or is, again, you're getting pushback on that? I'm sorry, I'm not meaning to put you on the spot.
Let me get back to you on that.
Thank you.
Could I just make one other comment about, as you brought up the burden of disease, we've been trying to use these data to develop the burden of disease for Matlab and then for the larger scope of Bangladesh. And we're struggling with those numbers. We have some conflict over those numbers. But what I can say is that most of these disabilities are not even a part of the calculation of the burden of disease. So as we move forward, I can tell you that the burden looks like it's probably twice the level that was first calculated for Bangladesh in terms of maternal health.
Well, and the reason they're not part of the global burden of disease is because there isn't any data to calculate the numbers, right? So there was a question in the back, I think. Yes.
Hi, Rima Jolove with the White Ribbon Alliance, and I just had one comment about the measurement from Marge's study, and I'm wondering about, and it feeds into the idea of postpartum care, that when you look at genital prolapse, the timing of when you measure it is really important, because in the first 42 days, at least from the global literature and systematic reviews, there may be more pelvic floor disorder after a normal delivery, but it depends on the time that evens out. That may be somewhat physiologic, and some of these other things too. I mean, it's hard for me to believe that there aren't mental health consequences from complications, particularly maybe as those complications bear out in the lives of women. If the average duration of living with a fistula is 5 years, maybe at 40, in the first 6 weeks, the burden of that mental health sequela might not show up. So that was just one thing for discussion. But the other thing that just going on the programmatic thing, it occurs to me, I sit on the board of an organization called Centering Healthcare International, and it just occurs to me that group prenatal care and group mother-baby dyad care is a way to address so many of these things, and that maybe as a proof of concept and something to test out might be very, very effective in looking at morbidities and how getting women together in a group, bundling care as you were talking about, so that you have the family planning and you have the baby and the mother all together. So that was just for discussion by the group.
Yes, correct. In terms of when you diagnose these problems, I think we had looked, we had no fistula in our arena. We did have the prolapse. We did look at depression 6 months out, and I can't recall whether 1 year out, and the depression essentially had gone down. It was not vibrant at that level, at the initial levels at all, after the first 6 weeks. For just the complications, for the perinatal, for the mothers who had a perinatal death, it was much more acute, as you saw in the slides. I think what was surprising to us is that we saw mild consequences at that point. But again, the women who have severe morbidities, the complications, are stigmatized to a large extent, and we suspect we also may miss them, even in a MATLAB setting.
Yeah, and I mean, you mentioned this briefly in your work, but there's other work that's been done by people from London School showing that not all the women who initially survive a severe complication actually survive in the long term, so that within a year or so after the birth, there may be women what are essentially maternal deaths, but aren't counted that way because they occur after the 42-day window. And that's another area where, it's, I think, very under researched and not very well known outside of the small group of people who work on this issue.
There is all of these studies we are putting out in a supplement to the Journal of Health, Population, and Nutrition, which hopefully sees the light of day by New Year. This is the Journal of Health, Population, and Nutrition of the ICDDRB, and in that compendium will also be a study from Rajasthan with Kirti Iyengar, working from ART, the Action Research and Training for Health program in Rajasthan, and her program also saw continued increase in maternal mortality or women's mortality post the 42 days. So similar to Veronique Philippi's work, I think it's in Burkina, where she saw this extended period of time where you have mother's death from the complications or mother's death period during that period. We're also seeing this in Rajasthan now.
The other question that I had, Marge, for you was the work that we're supporting in Sri Lanka on measuring maternal morbidity is finding a lot of gestational diabetes. In fact, that's the largest proportion of the morbidity that they're finding. Is that something that you didn't look at, or? Yeah.
No,
okay.
very unfortunately, we did not.
Yeah. Okay. Yeah, because it's something that is relatively common even here, but they're finding that it's a big issue in Sri Lanka. Any other questions, comments, stories? Okay, well, thank you all very much for coming. Thank you very much to our speakers, and please come to our next event in mid-October. Thank you.